So I want to thank you all for giving me this opportunity to take a few minutes to talk about a topic that I suspect is quite near and dear not only to my heart as a pediatric gastroenterologist who takes care of many adolescent patients, but many of you as adult GI docs as well. So I will say one disclosure I have is that I'm probably a huge hypocrite. I understand what I need to do, but whether I actually do a good job of transitioning and transferring may be up to question a little bit, as Millie might attest, and she was the lucky person to whom I transferred a lot of my patients when I left UNC. So we hope during our talk that we cover both some pediatric issues, including looking at children, what the differences are between kids and adults with IBD, and specifically focusing on the psychosocial impact of IBD on children and young adults who have IBD, looking at transition and specifically defining what transition means versus transfer, and then identifying current deficits and barriers that may impact how effectively we transition and transfer our pediatric patients to the care of our adult counterparts. And then Millie will cover the adult perspectives in terms of the transition and transfer process, review IBD transition recommendations and current available tools, and describe the overall goals that we have for effective transitioning. And so I'd like to remind people that children with IBD are not small adults. I can bear that out. But we have to remember this, both as pediatricians, but all of our adult colleagues as well. So there are really many similarities between pediatric patients who have IBD and adult patients from a GI symptomatology standpoint, extraintestinal manifestations. But I would argue that children and young adults often bear a disproportionate burden in many ways. We know that the clinical presentation is often more severe in children. From a Crohn's disease perspective, certainly the percentage of children who progress to requiring some type of surgery or multiple surgeries, and certainly more complicated forms, including penetrating disease and perianal disease. And in our patients who have ulcerative colitis, there is a significantly higher incidence of pancolitis. And then our kids who have both what we call very early onset IBD, those are children who are under the age of 5, and infantile IBD, those are infants. And in fact, my youngest patient was 10 and a half months old, and I suspect many of my pediatric colleagues here can also share similar stories. And with pediatrics, it's not just the severity of the gastrointestinal disease, but other things that are very specific to children and young adults, including growth delays, skeletal development, and delays in puberty. And really, I think the overarching piece that a lot of us struggle with the most with our families is the significant psychosocial impact of disease. Mike Kappelman published this over a decade ago, but this is still very relevant. And so Mike looked at the cost of disease in pediatric patients with IBD as well as adults. And so at that point, in his study, the annual disease attributable cost was $6 billion. We know that right now it's probably, depending on the studies, anywhere from $14 to over $30 billion. But the big piece is that when he looked at the overall per patient costs, they were significantly higher in patients under 19 years of age, which would be the pediatric population, when you compare it to their adult counterparts. So that really reflects on the severity of disease and really the unique burdens that children and young adults face. And this was a survey that looked at what parents are worried about when they have children with IBD. And there's a whole long list, but as parents, and I suspect that many of you are here, you can only imagine the fear and the stress and the angst that families have when you tell them that their child has a chronic illness. And so many of them will go through all the questions, but they worry about the futures of their children. What are they going to do? Are they going to be able to go to college? Are they going to be able to have, demanding or real jobs and really meet their dreams? And the other thing is the cumulative side effects of many of the medications that we prescribe or discuss. In terms of the pediatric perspective, there's a whole list of things here. This was from a few decades ago, but I'll tell you that this is still what we see in our practice. If you want to sort of group this into categories, I think the one thing for young adults especially is hearing that this is a chronic illness. IBD is lifelong. What's going to happen in my future? am I going to miss out or have to give up things that my peers do? And, you know, that overarching, this is just not fair. The other piece is appearance. From both the medications that folks can use, from not growing, from gaining too much weight, from not gaining enough weight, and how you're just going to feel and how that's going to affect your activities of daily life. So how are our kids who live with IBD coping? So Eva Sigathy has been really at the forefront of looking at children from a psychiatric perspective, and as she's found in numerous studies, depression is definitely present in children with IBD and more significant than normal, healthy children and teens. And a couple things that Eva and her colleagues have found include the fact that there's that increased disease activity and corticosteroid treatments, which, by the way, I despise as an aside, but we'll talk about that. That's my other disclosure. It correlates with depression, and that the majority of children with IBD have at least some mild depression, but those who have more of a somatic form of depression are usually those who have more active disease and or are on steroids. Other researchers and physicians have looked at the impact of quality of life and how it affects how you utilize the healthcare system. And certainly there have been similar studies done within the adult GI patient population as well. And so we know that when you've got a lower quality of life, you're going to utilize the healthcare system more, whether it's emergency room visits, hospitalizations, or just telephone calls, which we know can really be a significant burden both on physicians and our nursing colleagues alike. And then quality of life and social interactions are most definitely impacted overall. And depending on the studies you look at, upwards of half of the children who live with IBD will have some limitations in the activities of daily life. And as a pediatrician, I always tell my families and their kids from the get-go, I'm not here just to make your numbers look prettier or just optimize your medical therapies, which I want to do. If you have all those things in place and everything looks really pretty and perfect, but if you're not living a normal life and your quality of life is bad, then I'm still not doing my job, and it's a grade on me and not the child. So what about school functioning and performance? This really makes an impact not only on what a child should be doing, school is important, but how this is going to affect their future as adults, because how you do in school is going to have a downstream effect on what type of job you have, what type of life you will have by having the educational tools that you should be getting as a child and as a young adult. So Laura Machter and colleagues at Nationwide Children's found that children who live with IBD have poor school functioning when compared to their healthy colleagues. And they found that there was poor functioning in all the major domains, but the only significant differences were more in absences, although GPA and overall quality of life was also impacted. Interestingly, though, they found that disease factors like severity themselves were not significant predictors of poor functioning. Another group looked at the predictors for worse educational outcomes, and they found that when they looked at age and gender-matched children with IBD to healthy children, that the biggest predictors, and I've highlighted that, and that's why Eva and Lori's talk was so timely before this, was that diagnosis with a mental health issue, as well as lower socioeconomic status, but not age at diagnosis, type of IBD, or even steroids or number of hospitalizations had sort of the best or worst predictors, I guess, for how you do in school. So we always talk about psychosocial readiness, and I think sometimes as pediatricians, especially when we have more challenges, it's easy to say, wow, you're 18, you're a legal adult, great, you're going to see our wonderful adult GI colleagues, but the reality is we need to be a little bit more thoughtful about this. So is readiness and that process of transferring a chronologic age thing, or do we have to look at other factors? So this was a study from pediatric gastroenterologists in Australia and New Zealand, and they looked at numerous sort of factors about where young adults were sort of impacted in terms of being ready to going from pediatric to adult care. And what they found was that self-efficacy was certainly a factor that adult GIs felt were the most important, and that both the peds and the adult GIs felt that the biggest barriers were a poor medical handoff, meaning that we as pediatricians didn't do necessarily the most adequate job of giving the correct or the most complete information, as well as the patient's own inability to take responsibility for his or her care. And they really stressed in this study that psychosocial readiness is far more important than the chronologic age piece, which is not what necessarily happens in how we practice in real time. And you can see some of the areas they looked at: educational achievement, psychosocial maturity, as well as psychosexual maturity in these young adults. Our colleagues at Cincinnati Children's found very similar results as well, where they looked at psychosocial development in adolescent IBD patients and found that the bottom line is that, again, they were behind their peers in a lot of areas, including educational attainment and leaving home at a certain age, which is kind of important because I'm assuming that most of my adult GI colleagues may have at least had that one experience where the entire family shows up to that first visit. Typically, if you're not out of the home, you aren't even able to graduate from high school or get an independent job. It's going to be a little bit problematic to be independent. So how do we define transition? So you can see the words purposeful, planned, from child-centered to adult-oriented healthcare. And NASPGHAN, which is our Pediatric GI Society, again outlines that the goal of a transition program is for the patient to go through that continuum of care that includes really normalizing a lot of the things, including social and emotional development, and acquiring independent life skills. And you see in there's nothing that says you need to get to a certain point in terms of your medical therapy and being stable. So really looking at the whole patient. So what is the process of transitioning? And I think sometimes people interchange transition and transfer, and they're not the same thing. So transfer of care is when you move from one provider to another. So in the purposes of this talk, it's when the pediatric gastroenterologist transfers the patient to adult GI care, whereas transition is the piece that we need to be doing as pediatricians, where it's planned, it's purposeful, it's, again, that continuum, and we're really preparing our adolescent patients so that they can gradually become more independent and get to the adult care system. It's flexible and it's dynamic, and timing is crucial. So some of the fundamental principles are that you want services throughout this time period that are appropriate for both chronologic age and development, and I went too quickly there, and that teens and young adults with chronic illnesses also have similar health issues as their peers. So we focus on the disease often, but we have to also remember they're teenagers. So growth, sexuality, mental health issues, and substance abuse issues, which I have to say that these are some areas that I don't know that all pediatricians are really comfortable discussing. So the transition literature in IBD is certainly growing, given the known impact on ongoing clinical care. And I'll say that our colleagues in other fields, including endocrinology, where they've looked at patients with diabetes, and our hepatology colleagues have looked at how important it is to have more effective transitioning programs so that you can really improve clinical outcomes. So how does the literature right now look in transitioning in IBD? So we know that adolescent patients with IBD have lower baseline knowledge of disease and available resources than we'd like. And so some of the take-home messages of some of the additional studies were that we had to better identify what the deficits were, and that we had to have better ways of educating the patients, and that we found that, surprise, poor correlation between what the pediatric gastroenterologist thought versus actual measures to find literacy readiness on specific scales. And what we find is that we think that our patients are ready, but when you actually look at these readiness scales, they're not. And in fact, the lowest correlation was between the physician's perception and patient-reported self-efficacy versus the actual efficacy that the patients had. And this is really important. In fact, there was a recent study from Mount Sinai by Lori Kiefer's group and Marla Dubinsky's group that showed that efficacy was the primary predictor in seeing whether a patient would transition or attain transitioning skills effectively. And so this really shows the differences in how clinicians define health literacy and self-management and efficacy and how patients do it. So other discrepancies, and this really cuts to the chase, that, we always say that we have our pediatric-centered, family-centered style of care, and then there's that adult system too that's, kind of foreign to some of us. But the reality is we might think we're doing a good job, but a lot of our adult GI colleagues don't think we are. And I know that Millie's going to go through that a little bit more. But really, again, the bottom line is that we may not be helping our patients acquire the disease knowledge that they need and fostering that ability to advocate for themselves. And part of that just may be because we just don't have enough time or clinical resources. I think it's very rare to have an IBD center that has everything that you would like: social workers, dedicated transition counselors, psychology, etc. The other thing that came up, one of my colleagues did a survey recently, so it was Michelle Maddox in Kansas City. This was actually published a year ago in IBD Journal. She polled over 140 pediatric GI centers and found that only 14% had an actual written transition plan. So as we think about this, a couple things we know. Successful transitioning really does require education. It requires effective communication, not just between the healthcare provider and the patient, or the healthcare provider, patient, and parent, but also the pediatric providers with our adult colleagues. And so as we do this, we need to think of how we can better utilize existing tools and even determine if better tools need to be developed. So there are checklists out there, so we need to actually utilize them. There are educational tools, so if we're not utilizing them, why? And if we're utilizing them and they're not working, then how can we make them more effective? We need to continue to engage our patients and families actively. I think without a doubt, it's patient-centered care. It's not about the healthcare provider. It's about meeting the needs of the patients and the families and having a better way of doing a handoff, so a good written healthcare transition plan. And I will say, as someone who is actively involved in Improve Care Now, which is our quality improvement network for pediatrics, at this point we have 107 pediatric IBD centers, mostly in the US, but also in Europe and in Canada. So over 30,000 patients. And so within that group, I work with the clinical practice committees and the transition committee. And I will say that we've actually developed a transfer care summary that some of you in this room may have actually seen a copy. So we were trying to come up with a good, reasonable template that could be placed into the EMR that would really have a nice synopsis of all the major issues with the patient. But then we also polled parents and patients to find out what information they wanted us to give to the new adult GI docs. So I hope that at a future meeting I can actually give you updates as we sort of fine-tune that testing process. And so as I close out my talk, I want to say that there seem to be so many barriers that we deal with as we try to get our young adults from pediatric to adult care. There's a lot of things there, but I'm still convinced that we can make this better, and I'm so grateful to have a session like this as I hear my other colleagues where we talk about patient-centered care, dealing with the psychosocial issues, and really partnering, and I think this session is a testimony to that. So thank you.
Okay. I don't think I would even be on the screen if I used that step. So Sandy opened up by saying, kids aren't little adults, but I think actually adults, we're still kids in many ways. And so they're blurring of those lines. To start out, I just wanted to summarize from the adult gastroenterology perspective what we as a group feel about the transitioning process. And so this was a study that was a large survey of adult IBD providers. And providers ranked the importance of patient competencies, those things that they thought were absolutely necessary for that pediatric patient to really come into their practice and succeed. And unfortunately, providers found many deficits. And the deficits that they felt were most important were that those pediatric patients really didn't have knowledge of their medical history and their medications. The majority felt that inadequate medical history was received from the pediatric providers. And we'll go into that because as part of transitioning, one of the things that becomes very, very important is a summary, a written summary provided from the pediatric provider to the adult provider. And less than half of adult providers really felt that they were competent to address the developmental aspects and the aspects of mental health with adolescents. And so really having some of those issues addressed prior to this transition becomes very important. The factors that were ranked as most important for effective transitioning, again, included knowledge, medications, the accurate medical information that was received, and those that were seemed to be less important were the capability to undergo procedures under conscious sedation. Some of the nuts and bolts were felt to be less important. Attending the visit by themselves. I think we as adult providers are used to the idea that when a patient is transitioning, that parent is still part of that relationship. It's a process to gain independence for the child, and that's okay. That's less important than some of the other aspects. Ability to research the illness outside the office visit, again, less important. But let's focus on what those important aspects are. In terms of the patients themselves, when you actually look at patients in the age range preparing for transition and looked at self-management skills using a checklist, the factors that really improved as these kids got older were talking about their diagnosis, about Crohn's disease or ulcerative colitis, being able to talk to medical staff, including the nurses, about problems with treatments. They could name their medications. But very importantly, communication with the medical team did not improve with age. That's a skill that is independent of age itself. When you look at these summary scores on the checklist, here on the left axis is a composite checklist score. And as you can see here, age does improve disease knowledge. It really is independent of disease duration. But again, those communication skills are something that need to be practiced and aren't necessarily learned only with age. When you think about a timeline for what our pediatric colleagues need to be addressing as we get older in chronological age, really you can target it by age group. So at 11 to 13, really able to name their medications, they can talk about their condition. They may be able to describe how their IBD impacts their school and life. Age 14 to 16, really able to identify that medical team independently, have relationships with them, knows the names of procedures, their own medical history. Potentially, they could identify a support group that they may have contacted or been a part of. At age 17 to 19, this is really where we're trying to have them gain independence. They should be booking their own appointments, calling in their own refills. They should be able to tell us a little bit about their insurance plan, what it is at least. By age 20 to 23, they really should have scheduled an appointment with an adult provider and had that initial visit, and ideally done so when their IBD is stable. And so this is a continuum, and the transition can occur kind of throughout this time period, depending on when these patients meet these milestones. The competencies that really should be achieved by the time of adult transition are listed here, kind of a group of skills. I mean, these are things like being able to get to the doctor's office, to know who to call in an emergency, but also those knowledge aspects that become so important about their medications, what the potential side effects are, knowledge of sexual health even at this point, discussing alcohol, smoking, and drug use. Both of these skills and knowledge should have been addressed initially from the pediatric side and then will be reinforced from the adult side. One of the tools that we use at UNC is the UNC Transition Score. And I bring this up because it's a nice mnemonic for those things that should be addressed from a pediatric standpoint. So, you know, the type of chronic illness, the R stands for RX, what their medications are. Adherence, an important topic to address throughout the transitioning process. Nutrition, self-management. The I is informed about reproductive health issues. Contraception should be discussed with them from the pediatric side so that we can re-emphasize that from the adult side. It shouldn't be a new topic broached once they transition. Trade or school, insurance, ongoing adult support, and new health care providers kind of as you move from the pediatric to the adult side. When we prepare for this the actual transfer, the transitioning, remember, is this whole process we've been talking about, but the transfer. And so we really want to emphasize to the children as they move that there are going to be some differences. There are differences in style, management. They may be used to spending a very lengthy visit with their pediatric provider. So really letting them know ahead of time that time constraints are different, differences in procedures and sedation, planning for care at college, time away from home, balancing interests of the parent and the patient. And then really, as I mentioned, a very important aspect is preparing the complete medical summary which the pediatrician can send to the adult provider, but also is so important for that patient themselves to have a copy of. How do we help these adolescents manage their IBD? Really, we need to be proactive and provide appropriate resources. Work towards self-management. Again, education, preparation towards independence. And really importantly, as you've heard multiple times this morning, addressing those psychosocial factors become important in their success. So I'd like to finish out with just a couple of summary slides on what the recommendations are, what we should be doing as a group, pediatric and adult alike, to optimize this important time for our pediatric patients. And so from the pediatric perspective, really start seeing the patient without their parents for time periods of the visit. Discuss the benefits of transition to an internal medicine gastroenterology practice. I think many of these kids, when I first see them, they've developed such a relationship with their pediatrician, they feel like they're being booted out to something inferior. But you know, from an adult side, perhaps management of fertility and pregnancy issues, not something our pediatric colleagues are used to doing. Cancer surveillance, not as commonly done in the pediatric side. There are advantages, and emphasize those. This is why this is important that these kids transition. And really the pediatric colleagues should select an adult gastroenterologist who's really interested in these unique needs of young adults. They really are unique. Provide the necessary medical record, importantly that summary, and really allow flexibility in transition timing, meaning it's not a chronological age, it's clearly at a time period when the patient has met all of those letters in transition and has the self-management skills to succeed. Recommendations from the adult side, really we in the adult side need to be aware that adolescents may not recognize the differences initially in adult and pediatric care, and to help to orient them to some of those differences. Collaborate with the pediatric gastroenterologist early on. So for example, there's several different models of how to do this. At UNC, what we do is what I call the ping pong approach, where I go over and I see them in the children's hospital briefly in kind of one of their final visits with the pediatrician, meet them, more of a social meet. And then when they come to my clinic, the pediatric GI pops over. But almost most importantly, after they've seen me the first time, if you're in separate buildings or separate cities even, this can absolutely be done. It's very important for that child to actually go back and see their pediatrician on their own one more time after they've met their IBD provider. That way the pediatrician can reinforce and say, yes, I agree. You know, that really helps the child and their parents to gain confidence in the decisions that are being made. Anticipate questions from the patient, be ready with those when they first visit with you. Educate the patient on aspects of the adult healthcare system. And incorporate into your schedule that these first few visits are likely going to be slightly longer than your traditional follow-up visit. And be prepared for ongoing parental involvement, that you will reach the independence, but it's gradual, and really work with that family to make that at the right time. So finally, the summary. Get the patient ready for transfer. Make sure they have specific skills and knowledge. Get the parents ready for transfer. And we also, of course, need to get the adult gastroenterologist ready and well-informed at the time of transfer. The summary from the adult side, transition should promote continuity of care, improve treatment adherence, improve disease knowledge, encourage independent disease management, and build confidence in the new adult healthcare team. So really, overall, our overarching goal through this collaboration is to improve or maintain disease control. Thank you very much.